Please let me know when we are starting, right?
Good to go, start. Good to go.
Good to go. Okay. Yeah, fine. So hello, students. So we'll be doing the hematology, this NEET SS review. So I was really stuck up with a few things personal. That's why the delay. So so whatever questions I collected from the students and the DocTutorials team. So we'll try to discuss the exact the questions, and the options may not be the exact the same. Many of them are that, as we call it, is a recall. So we'll proceed. One sec. Yeah. So first question would be this is regarding a patient found to have some iron deficiency anemia. So with platelets around 6 lakhs. So what have to be done next in the workup of thrombocytosis? So basically they're asking about platelets of 6 lakh. That's their focus. So, and already it has been mentioned that the patient has iron deficiency anemia. So, with the background of this anemia and deficiency, how do you interpret this platelet 6 lakhs and how do you act on it? That's what they're asking. So option A is treat iron deficiency anemia and repeat the platelets. Option B would be doing a CRP to roll out. So there's basically if it is a part of some inflammation, because it's can act as an acute phase reactor. So then bone marrow aspiration biopsy. So D option, this is what I could recollect. So from the student. So what would you do next? So answer in this would be easy, I would say. So we should know the thrombocytosis, causes of thrombocytosis. So we have to exclude or include from that list. So this is a Harrison chart. So there is n number of causes for thrombocytosis, as we all know. First, any infection, inflammation, collagen vascular diseases, acute hemorrhages, malignancies, infections. So in our practice, it is iron deficiency anemia, which is given here, and any post-surgery, and definitely the myeloproliferative disorders, which grouped under the myeloproliferative disorder, there is polycythemia vera, myelofibrosis, essential thrombocytosis, CML. All these are grouped under this marrow-related, primary myeloproliferative disorder-related thrombocytosis. Then rebound collection of B12 folic acid deficiency, myelodysplastic syndrome, 5K, especially 5Q deletion is typically known to have thrombocytosis, hemolysis, post-placental hyposplenectomy. So here, then very rare thrombopoietin overproduction, JAK2 MPL mutation. So, so here they have already mentioned iron deficiency anemia. So this probably the question might be framed a little different. So what we can deduct is, so commonest is iron deficiency. So what we do is we can correct iron always and then recheck the platelet whether it is falling or not. So you can, from the CBC itself, you can get to this microcytic anemia. MCV will be very less. Anemia would be there. There might be some preceding cause like menorrhagia or any other bleeding manifestation or malignancies to lead to iron deficiency. So you can correct the iron deficiency, see whether the platelets are falling. And usually the iron deficiency anemia, the platelets may not be, this is 6 lakhs, kind of a mild thrombocytosis. So that would be the best way. CRP, yes, for inflammation or infections, you can really check. But here, iron deficiency anemia is already in the question. So probably that would be the best fit. Second question, which one of the following is associated with ischemic stroke? So we have given 4 options, 4 of all being associated to vascular occlusion. So here the focus is ischemic stroke. So okay, APLA option A, antithrombin 3 deficiency option B, factor V Leiden mutation option C, and proteinase deficiency option D. So probably they are asking some arterial stroke, meaning so arterial occlusion. So which one of the following? So probably here I would pick A, because antiphospholipid antibody syndrome. So this is associated with both arterial as well as venous thrombosis. And because APLA, we all know the what all antibodies which we look, it is basically like a hypercoagulable state in both veins and arteries. So the criteria, all those things you have to read up. So I'm not going to details of all this. So how can explore or include every from the given options. Other 3 antithrombin 3 factor V Leiden and proteinase, mainly they are they come into picture when we evaluate for a venous thrombosis. Okay. So, so primary increases the venous thrombosis, especially the DVT, pulmonary embolism, like that. So these are all inherited thrombophilias, usually associated with venous thrombosis. So ischemic stroke, probably the best pick from these options would be APLA. Option 3, patient was presented with fever. So there's a clinical scenario. platelet was given as 70,000. After investigation, he was found to have dengue. So this is a dengue fever with thrombocytopenia. So probably 2 days later, the fever subsided and platelet count improved. Okay. But after a week, he again presented with high-grade fever, TLC reduced, leukopenia, and thrombocytopenia. So bicytopenia, anemia with the third lineage, that is HB, they haven't given. So high-grade fever with the cytopenias, what will you do next? So first is peripheral blood flow cytometry. Again, I would like to say these options which I have curated from by the DocTutorials stream, but this is collected from students. There might be some difference, but we can go through the discussion, and you can even exclude and include whether if you have if you feel that the options were a little bit different. So peripheral blood flow cytometry, why would you do in first place? That's the question, unless you're suspecting some malignancies, leukemias, all. But here the clinical scenario is different, right? So the patient had a dengue fever, he had a drop in platelet, which is naturally expected. And after that, he again, as a second event, he developed a high-grade fever, or probably it could be a secondary infection, but the cytopenias are there. It could be sepsis, it could be anything. But flow cytometry as a first place, I don't think it should be the second option. B is serum ferritin triglyceride fibrin NK cells, bone marrow biopsy. So basically, they are looking at the possibility of a HLH. HLH is hemophagocytic lymphohistiocytosis. So is it that? It could be, right? It fits into preceding a viral infection. Usually it is preceded by some infection. Could be TB, it could be CMV, it could be dengue, it could be anything, EBV. These are the commonest. Dengue related HLS is very uncommon, but this EBV, CMV, all those are common. Okay, especially the Epstein-Barr virus. Tuberculosis related HLH is also seen. LDH, yeah, LDH is a non-specific marker, especially in this, he had a recent infection. LDH could be non-specifically high also, because LDH is something which can be high in malignancies, B12 deficiencies, hemolysis, anything can cause a rise in the LDH. So this, anyway, the question doesn't ask you about any or discuss about any hemolysis or anything. So procalcitonin, again, it's a marker of sepsis. But to fit in the framework of this question, procalcitonin is too non-specific for this. Okay, so probably here they might be asking about an HLH. So HLH, so option B might be the best pick. So HLH, the diagnostic criteria you all know, either a molecular diagnosis consists of HLH, especially the inherited HLH, and diagnostic criteria of other clinical criteria include 5 out of 8, fever, splenomegaly, cytopenias, at least 2 lineages, hemoglobin cutoff less than 9, or in infant is less than 10. Platelets less than 1 lakh, neutrophils less than 1,000, hypertriglyceridemia or hyperfibrinogenemia, fasting triglyceride more than 265, more than or equal to 265, and fibrinogen less than there is 150 milligram per dl. And hemophagocytes is documented in the tissue. It could be marrow, it could be spleen, it could be lymph node, but that criteria wise, the demonstration of the tissue is not may not be absolute criteria, because there are other criteria which can be that 5 out of 8 is necessary. It's not necessary that you should find a high hemophagocytosis in the tissue. Low or absent NK cell activity, ferritin more than 500, more than or equal to 500, soluble CD25 more than or equal to 2400 unit per liter, and other neurological criteria. So there is a neurological manifestation of HLH, CSF pleocytosis, conjugated hyperbilirubinemia, transaminitis, all hypoalbuminemia, hyponatremia. Okay, so for whenever you get an HLA, you score it whether it's an H score. Okay, where various parameters which is taken into consideration, and if it is a higher probability, you get a higher percentage of higher score in H score. Moving on to the fourth question. So this is the transplant scenario. So a patient underwent a hematopoietic stem cell transplant. So this they haven't mentioned. Probably they in the right question they might have mentioned there's an allo transplant. After which he was suspected to have acute graft versus host disease, acute GVHD. So treatment with steroids. So first line of acute GVHD is always steroids, IV methylpred. Then there is no improvement seen. So what drug to be added next? So they're asking about the second line management of acute graft versus host disease. Okay. So option A is ruxolitinib, option B is ibrutinib, or ruxolitinib we all know this is a JAK2 inhibitor, which is commonly given in polycythemia, myelofibrosis, etc. Ibrutinib, we know if it's a BTK inhibitor, Bruton tyrosine kinase inhibitor, commonly used in CLL, Waldenstrom, etc. And option C is rituximab, which is the first generation anti-CD20 monoclonal antibody used in various conditions, including B cell lymphomas and SLEs. So all B cell blockage is done by the rituximab. So what would be the next step? So acute and chronic GVHT, here we are, they have asked about the acute GVHT. So earlier, we used to say that acute GVHT is within 100 days. So time based division into acute and chronic, but it can overlap also. Right. So usually in a clinical setting or in a usual practice, it is the usually happens, acute GVHT happens in the first 90 to 100 days. Chronic GVHT, it's a entire, its pathophysiology is different. Acute is basically targeting the three main organs, which is the skin, liver, and the GI tract. So these three are the organs where you get the maximum antigen exposure. Gut, you know, all the gut mycobacteria, all the microbiota is exposed to the immune system. Liver, we all know the whole gut is drained from through the portal system into the liver, so that also get exposed. So liver is second thing. Skin, we know the largest organ, it is it's always in continuum exposed to other microorganisms. So these three are the organs hit mainly by the acute GVHT, while chronic GVHT is basically behaves like a what you call as a like a scleroderma. It's a proliferation, all those things happening in the multiple organs, be it in skin, be it in eyes, be it in genitals, be it in the muscles, all it behaves like a systemic sclerosis, that kind of a physiology, right? So both can overlap also, right? So as I said, the staging and grading of the acute GVHD you should know. So three main organs: skin, liver, and gut. So less than 25% involvement. So staging is 1, 2, 3, 4. Grading is given below. So staging based on the affected area. So less than 25% of skin, 25 to 50%, more than 50%, and generalized erythroderma is stage 4. Liver, as per bilirubin, 2 to 3, 3 to 6, 6 to 15, more than 15, very easy. Gut, more than 500 ml diarrhea or nausea. This is basically GI, lower GI, but there is an upper GI element also with nausea and all. More than 1 liter, stage 2, more than 1.5 liter, then ileus, paralytic ileus and continuous pain, that is the stage 4. Grading is basically stage 1 or 2, but no liver and gut, only skin involvement, that is grade 1. Stage 3 or stage 1 liver and stage 1 gut is grade 2. And grade 3 is basically liver and gut 2, 3 or stage 2, 3, 4. But the grade 4 is basically the skin, and that is the erythroderma. It could be even, even look like the burns exfoliation. That is the grade or stage 4 erythroderma. Okay. And stage 4 liver. So this is how you stage and grade a acute GVHD. So the guidelines says the first line treatment for acute GVHD is systemic steroids, 2 mg per kg, or even IV methylpred. So major improvement is there, then taper the dose and stop treatment when the GVHD sign is severe. But if no response, then or progression in 5 days, then steroid resistance is labeled, and then you start the second line treatment. Or if you have a trial, you can very well enroll in a clinical trial. So grading and staging, again, we can, for the earlier grades, you can give topical agents, topical lotions, and steroids, cyclosporin. Grade 2 oral corticosteroids, grade 3, 4 IV methylprednisolone. And definitely they will be having the allo transplants will be having GVHD prophylaxis going on parallelly. But if you have a GVHD precipitating, then you have to act with the steroids along with continuation of the cyclosporin or MMF, whatever you have in parallel, right? So then ruxolitinib, so second line option, which is USA FDA approved. So ruxolitinib has been approved as an earlier agent in acute GVHDs by the REACH trials. Okay, so REACH, REACH, REACH trials, because we, when I was doing my fellowship, our center was also a recruiting center for this REACH trial, that is for chronic GVHD ruxolitinib. I was also a principal investigator in that. So basically, ruxolitinib is added earlier. Then other agents include methotrexate, pentostatin, that is basiliximab, and daxglizimab, that is IL-2 receptor antibodies, anti-TNF alemtuzumab, and sirolimus, which is an mTOR inhibitor, and other mesenchymal stem cell therapies, MMF, rabbit ATG, fecal microbiota transplant for GI, GVHD, monoclonal antibodies, alemtuzumab, vedolizumab, alpha-2 antitrypsin, extracorporeal photopheresis. This is basically for chronic GVHD, skin GVHD, extracorporeal photopheresis. So correct answer would be A. So acute GVHD, first line steroids, then if improvement, then second line agents include ruxolitinib, JAK2 inhibitors. In REACH, the trial is REACH. Ibrutinib, a BTK inhibitor used in B-cell malignancies, CLL, and chronic GVHD, but not in acute GVHD. Rituximab is an anti-CD20 for B-cell disorders, but not for GVHD. Fifth question, a patient is worked up for anemia, a smear is given, which is the best drug to treat. So you can see some microcytosis and isopoikilocytosis, some sickle cells like this, some neutrophil here, and platelets are adequate. You can see the scattered platelets here, which looks adequate or even a bit high. It depends on the field, but it's more than adequate. So the classic is the sickle cell RBCs saying here. This may not be the exact smear that might have been given in the exam, but for the demonstration purpose, this is what they have asked. And from the options also, you can narrow it down. These are all drugs used for sickle cell. So smear, if there is smear or not, doesn't make much difference. They can very well give it. So we have to connect the smear with the drugs. So voxelotor, hydroxyurea, crizanlizumab, L-glutamine. So probably this is the closest question framed. So all are drugs used for sickle cell anemia. So which one would you pick? So voxelotor, it's a HbS, that is a hemoglobin S polymerization inhibitor. So it directly targets the root cause of sickling. Okay, so FDA approved for treatment of the hemolytic anemia and SCD. So it improves the hemoglobin and reduces the destruction, which is the reason for the anemia. Hydroxyurea in India, it is a first line because it is an HbF inducer. So, okay, and reduces the sickling and complication. But the problem is longer duration, the leg ulcers, all those things can happen. It is a broader action, but not specifically. It's a not like voxelotor. It's a directed action. Crizanlizumab, again, it prevents this crisis. Okay, to basically p-selectin inhibitor. So blocking the p-selectin, the adhesion will be gone. So neutrophils, all those things, the adhesion will be gone. So it will help you in the prevention of the crisis. But again, the newer data comes after the phase 3. It may not be much of a over the placebo. It may not be. It came as a much hype, but it's not routinely advocated in our routine clinical setup. Does not improve anemia, but it only decreases the crisis. L-glutamine again reduces the oxidative stress and crisis frequency, but minimal impact on anemia. So key distinction, so hydroxyurea is a cornerstone, especially in India. Voxelotor not available. It is the best choice for anemia acid because it is a direct first-in-class medication, mitigates the hemolymph by stabilizing. Yes, it is specifically approved for this purpose, making the most targeted option. But voxelotor, much in we can, if we read in more into the voxelotor, it's the first affinity modulator. Disease modify potential by increasing the hemoglobin levels and decreasing the hemolysis indicators in sickle cell patients. So it seemed to have a safety profile which is quite acceptable. But in November 20, so it is approved, accelerated approval by the FDA in November 19 for 12 years and more, first in class medication. And by 21, it approved for pediatric 4 to 11 years also. But the Pfizer is the manufacturing pharma. 24 September, there is a voluntary withdrawal of voxelotor from all global markets due to the concerns of this potential for serious safety events, including fatality. So it has been taken out. So of the options, best answer, at least in our setup, would be hydroxyurea. Sixth question, Again, I think the examiners this time is very fond of sickle. Probably sickle is something which you all can read next time also. Patient was present with hematuria, workup was done, HPLC was provided along with HB type percentage. So probably hematuria, acidonuria, etc. can happen in sickle cell anemia. So HbA is 38. So this HB LC or HB fraction graphs are very important. So you have to go through this HbLC graphs of all this thalassemia trait, intermediate trait, because intermediate is basically a phenotype, not a gene. It's a phenotype. So thalassemia trait, thalassemia major, sickle cell trait, sickle cell major, compound heterozygotes with HbE, HbC, HbD, Punjab, HbF persistence. All these things you have to go through because these graphs may be asked, or like this, the fractions can be given. So here A is 32, 38, and F is 2. S is 57, so above 50, probably sickle towards sickle cell anemia. A2 is 2.8, probably not sickle beta thal compound heterozygote. So the options sickle cell trait, not because it's crossed more than, it's usually sickle cell trait is around 40, 30. So here is 57. So it is more into a sickle cell anemia. Thalassemia, definitely not with this S fraction and A2. So here it is probably sickle cell anemia. S is present at high levels, and A, it's a normal interpretation of the graph. So basically you have to go through the pictures and how to interpret the graph. And HbE, so HbE usually elute or migrate in HbA2. So if you have a very high A2, mild elevation in A2, we all know it is HB, say if it is 6-5 percentage, it is beta thalassemia trait. If A2 is more than like 50, 60 around, so it is basically the HbE, right? So like that you have to remember. So here, the most likely it is means of the options, it is sickle cell anemia. So seventh question: a patient with non-history of gastric carcinoma now found to have a elevated serum creatinine, thrombocytopenia, bilirubin, LDH with ADAMTS 13 activity 45, which is the treatment of choice of this patient. So malignancy, solid organ malignancy, now presenting with a renal failure, thrombocytopenia, bilirubin. They probably, I haven't gotten what type of a bilirubin, hemolysis probably, LDH elevation. So hemolytic, microangiopathic hemolytic anemia, most likely because renal thrombocytopenia, bilirubin elevated. So microangiopathic hemolytic anemia in a patient with gastric carcinoma. So evaluation found ADAM-TS. So probably MAHA, they work TTP, microangiopathic hemolytic anemia, TTP. So they have checked the ADAM-TS 13 level. It is 45%. So what would be the treatment of choice? So this much of we can easily deduct from this question. So what would be the treatment option in a TTP with the slightly low? It's not severely low ADAM-TS, low. That's what we can say. Low ADAM-TS with in the background of a gastric carcinoma. So if would you do a plex, that is the plasma exchange, eculizumab or steroids? So steroids, first and foremost, in any TTP, steroids don't have a first line role. Okay, so that is easily excluded. It can be added on, but those who are resistant to other first line management, but it is not usually indicated as a first line. Eculizumab, yes, this complement inhibitors, but availability, cost, everything. These are practical issues, but they're not asking about the practical issue. What would be you do in a specific scenario? So for me, it is first plasma exchange would be a better option because they're giving, we have discussed all this thrombotic TTP we have diagnosed, and microangiopathic anemia with all this. TTP is a deficiency of ADAM-TS, which lead to accumulation of ultra large von Willebrand multimers, resulting in a microthromby in the small blood vessel, that is microangiopathic hemolytic anemia. And ADAM-TS is 45. This is a partial deficiency, it may usually associated with the TTP. So plasma exchange, probably you replace the the plasma exchange mean plasma is exchange that removes this autoantibodies that inhibit the ADAMTS and replace the missing enzyme, which can help the symptom reversal. Eculizumab is basically a C5 monoclonal antibody inhibiting the complement activation, PNH complement mediated TMA, but not for the other TTPs, but it can be taken as a second line. Steroids, as I said, not for the primary treatment. Combination, yes, there can be. In a refractory case, yes, there can be. But most likely, crucial treatment means option would be plasmapheresis. So that's it. So that's what I can take from the team for the hematology. So if you have any further question or any clarification, you can do message in my WhatsApp group or that's what. Okay, then thank you, students. Yeah, I think, shall we stop? Yeah, team DocTutorials, hello. Hello.